Now for some considerations regarding exposure ascertainment. That is, thoughts on how we should avoid biases with how we measure drug use, both in drug outcome studies but also in drug utilization studies. This talk is very directly inspired by two wonderful presentations I heard at the International Conference of Pharmacoepidemiology in Montreal quite many years ago, which was this double talk on epidemiology and pharmacology, the neglected halves of pharmacoepidemiology. And in this talk, the pharmacology part, there was quite a few wonderful quotes by Jacques Deloyer, who gave this talk, and he said, among other things, correctly classifying the subjects of a study into exposed or non-exposed constitutes the foundation of an pharmacoepidemiological study, since by definition pharmacoepi studies the exposures to drug, a sound knowledge of drug utilization, pharmacology and toxicology are essential to the design and critical appraisal of these studies. And this particular presentation is designed to address this core idea of why drug utilization, pharmacology and toxicology are essential to the design and interpretation of pharmacoepidemiological studies. So starting off with an example, consider the question of whether tranexamic acid causes problems of various sorts when given during hip surgery. So tranexamic acid is a drug that is given to prevent bleeding, for instance, in connection to surgery, and in this context, hip surgery. And we can, for instance, consider whether this affects bleeding risk, myocardial infarction risk, or stroke. That is how it affects the outcome designed, or whether it has adverse effects. So how is tranexamic acid used during hip surgery? Well, tranexamic acid is given as a single dose, administered once. It has a half-life of 3 hours. That is, after this particular dose, you are exposed for half a day or a day at most, and then you're basically unexposed from there on. And also there is the issue of how we identify tranexamic acid. This is standard, and it's not a particularly expensive drug, so not every surgeon might code the administration of this drug, so there's uncertainty as to how to measure this. In this particular context, we need to consider then it's not a matter of 30-day risk or 90-day or 1-year risk. It's probably a matter of only risk within the first few days where this particular drug is actually active, and the direct comparison of those with a code and those without a code might effectively be a mixed bag of comparing those with the drug to those with also the drug, however not coded. So this is a difficult one to address, and we need to consider these basic things before addressing the study question on whether this caused, for instance, MI. Let's take the exact same scenario, tranexamic acid or exposure, but during in the treatment of heavy menstrual bleedings. This is the same drug. It's not, of course, administered once and that's it. This is now administered during the menstrual period. However, we have several other issues that now needs to be considered. We might be interested in the same outcomes, but in this case we have prescription fills that won't necessarily correspond to the actual use of the drug. It will in most cases be filled in larger quantities at some basically random period of time and then used for the subsequent menstrual bleeds or not. Looking into the utilization patterns of this drug, the vast majority of women only fill 1 pack of this, making it almost impossible to identify at what point are they actually using the drug and when are they not using the drug. So any question like bleeding, myocardial infarction and stroke cannot reliably be assessed during use of these drugs when we expect them to actually be in the system and affect the risk of these outcomes. So in this other context, the same exposure and the same outcomes cannot be addressed at all. However, we might also consider, for instance, whether this drug affects melanoma risk. This has been seen in lab studies, including zebrafish, and thus this is a hypothesis born also into real world, whether we can see an effect of use of tranexamic acid on melanoma risk. Whereas this outcome could not be addressed at all with the hip surgery patients, as a single dose administered IV once is highly unlikely to affect anything long-term, we might actually be able to assess the use of this drug in terms of melanoma risk, since we are no longer, for a cancer outcome, particularly interested in knowing when are they using the drug and for how long is it in the system, but rather for a cancer outcome would be interested in the total amount used over an extended period of time, making it possible to look at long-term uses versus short-term uses and realistically assess the association to melanomas. So what you can do not only depends on the half-life and the pharmacological properties, but also coding practices and the use patterns, plus minus whether we have data on the actual timing of use, and to what study questions can be addressed. This is a different question, but also involving bleeding. This is the effect of using dicloxacillin. It's an antibiotic on the effectiveness on warfarin. Warfarin is measured, or the effect of warfarin is measured using the INR value, which is a relative measure of the thinness of your blood. The higher the value, the thinner the blood. Very high values will lead to bleeding. Low values increases your risk of having an embolism. Patients are treated so that they typically have an INR between 2 and 3. And in this plot, you can see on the left-hand side that patients have a median level corresponding to exactly this, between 2 and 3. The majority of users are within 2 and 3, and some are then slightly above and slightly below. In the study, we looked at the effect of dicloxacillin, and upon dicloxacillin treatment initiation, the values don't particularly drop for the first week, but then there is a steep drop persisting for a few weeks. This is due to two things. First off, dicloxacillin is a CYP inducer, and this increases the metabolism of warfarin. However, this is not an instantaneous effect. This is something that after a few days starts building up the enzyme capacity of the liver, and then after an additional few days you see a drop in warfarin levels. However, this is a penicillin, and you won't be using this for a very long period of time. So typically you would use this for 7 or 10 days, and accordingly, as you can see here, the effect of your warfarin bounces back up within 21 or 28 days. This is important information if you, for instance, wanted to do a study on the effect of using dicloxacillin among warfarin patients and the risk of stroke. In this study, we did look at risk of stroke, and we did a 21-day window assessment. However, as per the previous figure, having this 21-day window starting from dicloxacillin initiation makes very little sense, because that's basically not where you are at increased risk. So here we initiated follow-up 7 days after dicloxacillin initiation and followed for an additional 21 days, corresponding to the 28 days after dicloxacillin initiation. And understanding such a delayed mechanism will be important in terms of understanding the actual final sort of details on when an effect is seen, and designing a study to look at that particular risk window instead of diluting your effects using too wide of a window. And what window is interesting in terms of drug exposure differs by study question. Here, as in a sort of case control setup, we might want to look at what is done over the last 60 or 90 days leading up to the point in time where you are sampled as a case or control. But other study questions with delayed effects might actually realistically be less relevant what happens just up to a given time, but more relevant what happens earlier on, be it a year prior to that or in an extended period prior to that. And thus, in some cases, we might have to forego of some of our data material where we do not have the sufficient amount of follow-up, for instance, if we're looking into delayed effects. Here it is denoted as a case control study, that is, the assessment window of drug exposure is postponed back in time. In a cohort study, sort of like the dicloxacillin example before, this would correspond to cohort entry, but start of follow-up being delayed later on during the study period. And there are quite a few cases where such delayed follow-up might be of relevance, for instance, in cancer risk. And there are several reasons for that, some of which we'll get back to in a later session. One consideration or concern here is that drug use might change up to a cancer diagnosis. This is the rate of new use of any medicine leading up to a cancer diagnosis among cancer cases and random population controls. As you can see, there is a reasonably steep increase in drug use or new drug use just prior to a cancer diagnosis being established. This, as is expected, depends on the type of cancer. For breast cancer, which has a low number of symptoms that require medical treatment and a fairly easy, quick diagnostic pattern, there is a very small increase, whereas, for instance, in lung cancer, we see a very steep increase, which corresponds to, for instance, antibiotics for respiratory infections, analgesics, and a lot of other medication. Having such a pattern and understanding such a pattern and differentiating such a pattern from what is actually the causal agent of the cancer is quite important, because in most cases, if not all cases, this increase in drug use does not correspond to something causing the cancer. Rather, this is early signs of a later cancer that is not yet diagnosed at this point in time, but that is the actual cause of the symptoms that lead to this drug initiation. And understanding this phenomenon and understanding how this affects drug use pattern is quite important. And here's an example with the use of proton pump inhibitors and risk of pancreatic cancer. Pancreatic cancer and proton pump inhibitors have been linked together in quite a few studies by now. And here we did a similar study and ended up estimating no association, a odds ratio of 0.92 between long-term use of proton pump inhibitors and pancreatic cancer. In the main analysis here, we disregarded anything that happened 2 years prior to the index event in a cohort study that corresponds to starting follow-up 2 years after drug initiation. If we increase this lag period, which we applied because we really don't think what you did yesterday or within the last year affects your cancer risk today, since cancer is a delayed outcome, we could increase this up to 60 months or 5 years, and we saw little to no change in effect estimates. However, if we had shorter amounts of lag time, we suddenly saw a slight increase in the estimate, still not significant. And if we applied no lag time whatsoever, that is included drug use up until the index event, or in a cohort study started follow-up by drug initiation, we suddenly saw a very strong association between proton pump inhibitors and pancreatic cancer. This is not causal. This is simply used due to the fact that this is not a well-informed, pharmacologically and epidemiologically well-informed design. And as one might expect, in this context, we see that across literature, all the studies showing such an association applied no lag time. So basically, my recommendation is to deep dive into pharmacology and consult a pharmacologist or other people with knowledge about the utilization patterns in pharmacology and toxicology of the drug in question to inform your analysis. Another metric of interest in terms of pharmacoepidemiology is, of course, to decide whether someone is exposed to a given drug at a certain point in time. And typically we don't have exposure patterns or exposure periods, but rather prescriptions being issued or prescriptions being filled as a point in time. Sometimes that's more than enough to decide what is happening to a particular patient. For instance, in this context, we see a patient that comes back filling 2 prescriptions for ibuprofen tablets, and within a few days fills another prescription, and then shortly thereafter experiences upper gastrointestinal bleeding. Most will agree that this is likely a gastro-bleeding happening during ibuprofen exposure. However, we might see a different pattern such as this, where someone is filling ibuprofen and is doing so with a few more months in between, which isn't exactly compatible with using ibuprofen consistently throughout the period. But on the other hand, it is likely that there is some ibuprofen use at the time of this bleeding event. So deciding when is someone exposed, what is the duration of a prescription basically, is something that we very often need to build some sort of decision rules for. We leverage different type of data. Sometimes we have prescribing data, Sometimes we have field data, and basically we are trying to predict ingestion data, which we of course rarely, if ever, have. The difference between prescribing and filling will depend heavily on the drug and the setting and the type of prescriber. In a Danish context, we've estimated that 9.1% disappears from general practice. So about 9% of general practice prescriptions issued, they are never filled. So that's the best estimate we have in terms of this sort of gap. But other studies, there's only a few of them, but the other studies generally report higher rates in other countries, which is a measure of misclassification. And this matters a lot. This is a paper by my colleagues Jesper Halles and Henrik Støring, and part of a series of papers looking into the effects of how to decide prescription duration. So here we are looking at the NSAID upper gastrointestinal bleeding association. This is a known association. We know there is an association. We are defining use of NSAIDs either through fixed windows, so saying from one prescription in 30 days or 60 or 90 or 120 days onwards, you're considered exposed. Or we are saying, well, the amount you ingest is 1.5 DDD, 0.5 or 0.2 DDDs per day. So either fixed window or the amount filled divided by an estimate of fixed daily intake. And looking at the association observed in terms of upper gastrointestinal bleeds, these are the results. So basically, if we assume something with very short exposure periods, we see very strong associations. Whereas if we have long exposure periods up to, or rather down to the 0.2 DDD per day assumption, we see that the otherwise very strong associations are greatly attenuated. And why are they attenuated? Well, this is a matter of misclassification. So if you consider the philosophical question here, it's not a philosophical question, but let's assume it is. What is the height difference between men and women? And we misclassify some men as women or vice versa. That is, if you separate a room, men to one side, women to another side, and then take a few from one side and make them change their team. What will happen to the height difference upon this misclassification? It will, of course, be attenuated because you are sort of reducing the difference. You are making the difference less obvious because you are mixing the two groups together. And that's basically the same thing that is happening here, in that with very long exposure ascertainment assumptions, there are some people in the exposed category that are in fact not exposed. And thus you are no longer comparing exposed to unexposed, but you are comparing exposed to exposed and unexposed. Or you are comparing exposed and unexposed to unexposed, depending on whether you are having too long or too short of an exposure ascertainment window. So you will have misclassification and you will see your effect sizes attenuated. This is not the only difference, however. There's also another challenge here in terms of depletion of susceptibles, that irrespective of misclassification, the risk is increased, in particular in the first few days of exposure, meaning that even if you correctly classified people into users and non-users, with your assumption, the shorter the period used, the higher the risk, because the risk is in fact higher in the first period of exposure. So there's both a misclassification issue here and a pharmacological issue here. The same thing is, by the way, seen in the example used in the previous presentation on the NSAID use and upper gastrointestinal bleeding in Saskatchewan, the Garcia-Rodriguez paper. It is somewhat unlikely that the effect of, for instance, diclofenac with old past use, that is more than 6 days since you've last used the drug, is in fact the reason why you have an increased risk. It is much more likely that this is misclassified use, that some are saving some of that drug and some of them classified as old past use are in fact current users, just a smaller proportion than in the actual current use category. And this is part of the explanation, in addition to potentially a lingering effect, that explains why we see a slightly increased risk in the old past use. So sometimes this is reasonably easy to make assumptions. For instance, if someone fills statins, we can reasonably assume most statin users are filling one tablet per day. It might also be realistic to say you are using 1 aldronic acid a week, which is the typical use pattern. But what about an SSRI a day? Well, some might use 2 a day. That depends on the dose scheme. We do see that, and sometimes you see instructions reading something like 1 to 2 paracetamol 3 to 4 times daily, or even as needed. So in some cases, we can make reasonable assumptions about duration. However, in many other cases, we cannot. Jesper and Henrik have published quite a few papers on how to assess this, and I won't go into any detail whatsoever, just to highlight that there are methods used, referring to the waiting time distribution, to assess this directly and without a prior hypothesis on how to estimate duration, but have a data-driven approach to this. However, I want to use this specifically to highlight one point here, in that in this particular method we are able to estimate this in strata of the patient characteristics and the number of tablets filled and other characteristics for that matter. And here this is use of warfarin, and this illustrates that there are only small differences, however they do exist, on whether older patients or younger patients fill the drug. For instance, 100 pills, age 50 and 70, across men and women, we see that older patients have a longer period between interval refills, whereas younger patients have shorter intervals between refills. More importantly, and that's the point I want to make with this slide, that one would assume that twice the number of tablets denotes twice the duration of treatment, but it does not. In fact, if we, for instance, take male patient 70, there is a 80-day period between 100 pills filled, but if you go to 300 pills, it's about twice that and not 3 times that in the 160 days. The reasoning is simple from a clinical point of view. Those using a large amount of the drug will typically fill more, and thus it's not only a matter of the same use pattern extended, but actually a higher daily use, which would conflict with any decisions on simply 1 DDD per day or something similar. So when assessing drug use like this, it is, as illustrated, quite difficult. My only specific recommendation is to not apply a mystery box approach in which you rely on some algorithm or code that you aren't using or haven't developed yourself, but be very explicit about how you identify current drug use, and also test this using sensitivity analysis using other approaches, so that it is tested whether there is an impact from your definition of use. Another potential issue with the use is not only whether you are currently using or not currently using. We also see challenges in terms of cumulative use, in how to, from a pharmacologically well-informed manner, decide what is a relevant amount of use, for instance, in duration response analysis. This is a paper on the association between antipsychotics and risk of breast cancer. And in this fairly long text about how we decided on what to look for in terms of the antipsychotics and the thresholds applied to the dose-response analysis, we noted that first off, we had a priori defined metric of long-term use, defined as 10,000 milligrams of olanzapine or equivalent amounts from other antipsychotics, argued on the basis that it is largely arbitrary, but it should be a substantial and long-term use if it should affect cancer risk. One might be tempted to look at risk among users and non-users, that it corresponds to an ever-use metric, but realistically, most users will not get to a place where this actually affects cancer risk. And this also doesn't inform clinical decision-making, in that there is no concern of a cancer risk with short-term use, which olanzapine and other antipsychotics are commonly used for. So we need a study that addresses what are the risks if you have long-term use. In this study, we then divided people into the case control study, users, ever users, and long-term users, and cumulative use. So while we saw 5,000 ever users, we only saw 700 long-term users, which clearly illustrates the fact that among the cases, which illustrates the fact that there are a very large number of people not getting to the amount of exposure that we would expect to affect cancer risk. In the cumulative use analysis, This is even sort of more obvious. For instance, if looking at the number of cases distributed, the vast majority of them are within the lowest threshold. A standard epidemiological approach would be to, for instance, in dose response analysis, divide patients into tertiles, lower tertile, middle tertile, and upper tertile of use. However, had we done this here, this particular study would have seen everyone in the first tertile correspond to very low use. The second tertile would also be very low use, and in fact, the upper tertile would even include people from the below 5,000 milligrams here, because the use is skewed towards short-term use. So a standard EPI approach of simply dividing by tertiles of use will completely obscure any association seen with very long-term use, which is, however, not the dominant one, still something that happens fairly often in clinical practice. Another example is this one, where we looked at the use of hydrochlorothiazide in skin cancer. As shown in the figure here, there is a quite pronounced association between long-term use of hydrochlorothiazide and in particular squamous cell carcinoma, the upper line. This is evident from this dose-response analysis that was a priori decided and informed by the use patterns and to see what are the risks with very long-term use. Had we applied the standard approach of tertiles, this would correspond to a first tertile with no risk, second tertile with no risk, and this very illustrative gradient would have been lumped together into a third tertile, which would have showed only a marginally increased risk. So be wary of using standard EPI approaches and instead use pharmacologically well-reasoned ways of identifying amount used. Another concern with defining use is the difference between continuous use and current use of a drug. This is from a paper in Pharmacoepidemiology and Drug Safety, comparing two different ways of assessing whether someone is using a drug. The top one asks the question, are the drug user currently using the drug at day X after treatment initiation? Which means that if you, for instance, stop using the drug and resume drug at a later date, you can be included in the numerator. In the second one, the Kaplan-Meier approach, this is a matter of have you continuously used the drug up until day X, which then means that if you had a small lapse in treatment, you are classified as a non-user and you will remain as such regardless of whether you later initiate your drug treatment. This might be reasonable if what you are assessing is continuous use, but as illustrated here, there can be substantial differences between the number of continuous users in a classical Kaplan-Meier approach and the number currently using the drug, as in this proportion of patients covered. More importantly, the two methods also are heavily reliant on the assumptions made in terms of duration, in particular the Kaplan-Meier approach. In the Kaplan-Meier, that is the continuous use not allowing any gaps, as evident from the rightmost figure here. If you have defined drug use as number of tablets plus 60 days versus having defined it as number of tablets plus 180 days as your current use metric, there is a substantial difference here of almost 25 or 30% in the estimate of the total amount of individuals still in treatment after 3 years. This is perhaps not even the most dramatic example that I've seen. So how you define your current use and continuous use, both in terms of whether allowing small gaps, but also in terms of how you define when a gap is present, will heavily influence your estimates, as illustrated here, also in a descriptive drug utilization setting. And drug use isn't a random event. It's important to remember that quite a lot of what is happening with drug use is closely tied to the clinical course of the patient. Here, we've illustrated the total use of topical medication among people with psoriasis. And so many of these patients are treated in general practice, and here we've anchored their drug use on the first hospital contact. And similarly, as we saw with the cancer patients and drug use, we saw there's an increase prior to the hospital contact, likely corresponding to a worsening of the symptoms up to a physician deciding to refer to a specialist. Upon hospital contact, there is a short-term increase in use of various medications prescribed likely by the hospital physician, but over time this is sort of drops down back to the levels prior to hospital contact. And this is quite important to remember that in assessing, for instance, what is happening to patients followed in an ambulatory setting or via specialist or initiating a new drug, that quite a lot of what we see with drug use is actually a temporary thing. So, for instance, describing when are people initiating and how quickly are they off their treatment again is quite important to inform your pharmacoepidemiology study, be it outcome or drug utilization. So, in summation, I very much adhere to Jacques Delorier's point on pharmacology being the neglected half of pharmacoepidemiology. Please pay attention to your pharmacology.